Welcome to AETCM, the Emergency Medicine channel. Today we will be discussing an abdominal case which presented to our ER. Then, can I start, sir?
Yes.
A 72-year-old female was brought to our ER with complaints of constipation since 5 days actually. Initial 10-second assessment, patient was drowsy and not obeying commands. Her airway was patent. There was no pooling of secretions, hoarseness or any foreign bodies. Breathing, her respiratory rate was 17 per minute with a saturation of 97% on room air. Air entry was bilaterally equal with no added sounds, and chest exertions were also normal. Circulation, her heart rate was 115 per minute with a blood pressure of 150/80 and MAP of 105. All peripheral pulses were felt equally and bilaterally. Disability, her GCS was E3V4M6 and her pupils were 2.5 mm equally reactive. Exposure, her temperature was 98 degree Fahrenheit and GRBS was 143 milligrams per deciliter. So adjuncts, since she was...
This point is more of a constipation with a bit of drowsiness. That's
drowsiness,
no other
yes.
positive findings at this point.
No, sir.
Examination, you didn't find anything significant as of now.
Yes. So, we have a drowsy patient with a history of constipation. So, as a part of adjunct, I asked for an ABG. It was showing a pH of 7.44, PCO2 of 42.8 and bicarbonate of 28.5. Lactate was 1.5, slightly metabolic acidoalkalosis with a potassium of 3.3 in the ABG. So hypokalemia is also there. So I asked for an ECG to rule out hypokalemic changes. There was only sinus tachycardia. There was no U waves or PR prolongation or ST depression.
Sodium? ABG?
Sodium was 139.5, sir, in the ABG. Creatinine was 0.57. So, since there was a history of constipation and drowsiness, we are not sure whether she had some vomiting episode and aspiration or something. So, I asked for an X-ray abdomen also. It was showing dilated bowel loops, small bowels and large bowels were dilated, sir. So I want further history, so I went into sample histories. There is no history of allergies. There is a past history of LSES 30 years back. And she is diabetes and hypertensive. For diabetes, she is taking insulin and metformin 500 with 10 gliptin. And for hypertension, she is taking cilnidipine 10 mg twice.
Duration of both?
More than 15 years. This patient had a history of constipation since many years, and she used to induce stools by flushing water through a pipe to the anal canal. And since the last 6 months, her symptoms worsened and was taken to outside hospital and on OG.
How many days?
6 months.
6 months.
And she was not able to flush out her stools. So one OGDscopy was done outside, which was normal, and colonoscopy was done, which was showing impacted stools in the right colon with internal hemorrhoids. There also an X-ray abdomen was taken, which was showing only dilated bowel loops. There was no air under the diaphragm or anything. So they advised some laxatives, and they did some mechanical evacuation, and they advised laxatives for her. Later on, what happened was she had low mood, reduced sleep and all, and so she was taken to a psychiatrist and she was diagnosed to have depression, and they've given her clonazepam and all.
That is a recent?
Yes, sir, since 5 months. So after that, she was always remaining very drowsy and her constipation worsened and her food intake also reduced. So, and she was confined to bed for the last 2 months. Bystanders noticed that there was progressively distension of abdomen with constipation, worsening of constipation, and recently she was taken to an outside hospital. That time her potassium was low, around 2.8. So they have started IV correction, and they took a CT abdomen to rule out any mechanical causes. That time they found that she is having large bowel loops, dilated large bowel, 7 to 10 centimeter in size, with loaded colon and loaded with feces and minimal ascites.
You told confined to bed, whether it is total confinement or in between she used to ambulate.
It was gradually, sir. Since the last 2 months, she is totally confined to bed.
She is not moving, getting up from the bed and moving.
No, sir.
You told large bowel dilatation was 7 centimeters.
7 to 10 centimeters.
Significant.
Yes, sir. Actually, a small bowel, if it is more than 3 centimeters, it is significant. Large bowel more than 6 is significant. Cecum itself more than 9 centimeters significant.
3, 6, 9 total. Okay.
Then enema was given from outside hospital like 5 days back, and then she passed stools. Then she was again discharged, and in home since the last 5 days she was not passing stools. Obstipation history is not known because she is confined to bed and bystanders are not able to tell that. Micturition, she was passing, she was bedwetting. So in the recent hospital admission, she was kept on Foley, sir.
What is the implication of asking all this?
Sir, consciousness, sir.
Pardon?
It is some spinal infection or something due to bowel bladder involvement.
There will be retention or there will be...
And bed sores.
Yes,
Diabetic patient for long time. Okay, bed sores may also develop. The motility itself will be reduced. She may go for deep vein thrombosis. Okay, all these complications once 70 years, female patient and bedridden for long time.
Yes,
This also should be always kept in mind.
Okay.
Any drugs or anything, suddenly the patient going for dyspnea and then sudden cardiac arrest. Maybe one of the reason may pulmonary embolism also.
Okay.
So what are the complications the patient may be having? So till we rule out.
Associated complications. There is no history of any fever or multiple episodes of vomiting or anything, sir. There is no history of any breathlessness also. I went ahead with the examination, sir. Initially I went into per abdomen examination. Per abdomen inspection, the abdomen was distended with no visible bowel movements or any ventral hernias. There was a classical cesarean scar on her abdomen, but there was no hernias over that. Umbilicus was central and inverted. There was no Cullen sign or Great Turner sign. Inguinal region and hernial orifices were normal, sir. Palpation, abdomen was tense on palpation, sir, but there was no tenderness elicited, and abdominal girth was 78 centimeters, sir, at the umbilical level. Auscultation.
Both two things. One is gaudy. Number two is rebound tenderness. These are all most important. Any pertinent involvement is there.
Yes, sir. Then auscultation was.
What's the relevance of abdominal girth?
Abdominal, we have to monitor the abdominal girth, sir. We can find whether it is improving or it is worsening to our treatment. Then auscultation wise, auscultated for bowel sounds, sir. Bowel sounds were actually present, sir.
So present, normal or sluggish?
It was, we should hear at least 3 sounds in 1 minute, sir. We were able to appreciate that. Percussion, abdomen, percussion, tympanic on percussion, sir.
So what will you rule out? Any fluid?
Fluid should be ruled out. Then CNS examination, her GCS was E3, V4, M6, pupils were bilaterally reactive, her tone was normal and she had normal sensation to pain. When we were putting IV cannulas and all, she was having sensation to pain and she was withdrawing her limbs. Reflexes were normal, sir. Other things we couldn't examine in her. Cardiovascular system examination were normal and respiratory system examination also were normal, sir. She didn't have any aspiration features, maybe because she was not taking any feeds from outside hospital.
So what do you expect? She is not taking feeds, whether she had any other way of supplementation of the food, or else what will happen?
She will lose her electrolytes and everything, sir. She going to malnutrition.
Because of the long time stasis of the malabsorption. So we can anticipate protein level and essential vitamins. And if they are all reduced, automatically intestinal flora, see other pathogens may harbor, and it itself may induce certain
infections.
Okay. And with respect to this patient, diabetic. So one more thing is GERD. Lower esophageal sphincter tightening will not be there. Good. Carry on.
So
these are things important. Why? Because chance of aspiration.
Yes, So we have a case of intestinal obstruction with a very low GCS, sir, and a history of depression is also there. So we went ahead with their investigation, including a thyroid function test and electrolytes, sir. So total count was 5,000 with a hemoglobin of 13 and platelet was 5 lakhs. CRP was 96 and her potassium was 3.3 with a urine potassium of 17. Sodium was 139, magnesium was 1.8 and phosphorus was 1.4. So, TFT, T4 was 0.7 and T4 was 1.1 and TSH of 0.7. It was normal, sir.
So what do you want to arrive at by doing the thyroid functions?
Hypothyroidism, there can be associated depression and constipation will be there.
Motility will also be reduced.
Affected. Then she was on a Foley's from outside, sir. So, that sample was having numerous pus cells.
How long she had been on Foley's catheter? When was it last injected?
Like 2 weeks back, she was admitted in outside hospitals, and that time it was placed.
As a rule, there is no point in sending a urine routine from a catheter which is in situ for more than 48 hours. Okay. Anyway, you are going to find something abnormal. So if there is a strong suspicion, better to send in a fresh sample rather than sending from an already placed catheter.
Yes,
and one more thing is, these patients at this age may not be having any fever, any constitutional symptom.
yes,
Even though there is an infection, they may go up to the level of sepsis without any fever. And number two, in the cardiovascular system, diabetic, old age, most importantly, you have to check for orthostatic hypertension.
Yes.
Okay, so just lying down and elevate little, and then check any differences. Okay.
So this patient was taken into our ICU. She was kept NPO and she was inserted with an RT and continuous aspiration was started. Meanwhile, we were going ahead with our investigations, and abdominal gut chart was
any aspirate?
greenish aspirates were coming, sir, like less than 5 to 10 ml per hour.
How do you make a continuous aspiration?
Sir, we will be inserting a Riles tube and we will be connecting that to the urobag. Or
Keep it
open.
Gravitation.
Based upon the nature of the aspirate, will you get any other additional information?
Bilious, then
the obstruction is after the CVD, then it will be bilious, and before it will be non-bilious.
then fecal large bowel.
Okay.
We were planning to go ahead with the CCT abdomen, sir, to rule out any other mechanical causes of obstruction are there. CCT showed grossly dilated bowel loops till the anal canal and the dilated cecum of 7 cm, and the bowel loops were more than, large bowel was more than 10 cm. There was no perforation or stricture narrowing seen. There was minimal intrabowel fluids, and they were suspecting query pseudo obstruction. So there
you
were
have gone for a contrast enhanced CT.
contrast enhanced CT.
Okay. What is the additional information you are going to get from a contrast enhancement from a routine CT in this patient?
Sir, we can, other than the air fluid levels, we will be able to see any mass lesions or any liver pathologies or anything is there.
External nodes is something, external compression as well as
Intraliminal or extraliminal?
both.
So if
can
there's a mechanical obstruction, you have an edge. For a normal intestinal pseudo obstruction, a CT plane is good enough. So suppose this patient was having a renal failure, and you would like to get more information other than your plain CT scan. What are the options?
Either we can go for MRI scan, MRI with the contrast of the abdomen, or gastrography, depending on
an
the
oral plus a rectal contrast to understand the zone of transition.
Yes, sir.
And on a practical base, even gastrographin has bit of therapeutic effect.
Yes, sir.
Patient whom you give gastrographin after the scan usually passes towards also. Okay, so just keep that in mind. Fine.
We have a patient with a intestinal pseudo obstruction and depression, sir. We have to rule out, she is having a low GCS, so we have to rule out any other causes there which is contributing to the low GCS other than this depression, sir. For that we have to plan on a neuroimaging also. For that we have did an MRI brain with contrast which was showing some acute infarcts in the right some lacunar infarcts in the right centrum semiovale by thalamic region and also. But it was lacunar infarct only small, but that itself cannot explain the slow GCs.
Thalamic, or she having any weakness?
No sir, weakness as such we cannot elicit sir, because
No
focal deficits were not there. So we planned for a colonoscopy and colonoscopic decompression, and colonoscopy was done. It was showing normal bowel loops, and a colonoscopic decompression was done for this patient. Then after that, after the colonoscopic decompression, we have along with that we have to correct the dyselectrolytemia. He was having hypokalemia, so that was also corrected, sir. Initially her potassium was only 3.3, so we placed an EJV and we corrected the potassium. But even after correction, when we repeated, she was again having this hypokalemia. Her potassium was 2.8, 2.6 like that. So we had to place a central line and correct the potassium. Along with that, she was having hypomagnesemia also. So these were also addressed, sir. Then since she was not passing stools, she was kept NPO. Then while we were monitoring her, her sodium level started increasing. So initially it was lab sodium was 140, gradually started worsening to 150, 160.
What role were you giving the patient?
We were giving a normal saline, sir. So it can be hypernatremia secondary to the
Chloride
fluids.
levels were needed?
Chloride levels was VBG
Along
sample
with
was
hypernatremia?
113.
It was
It was not correlating actually, sir. So maybe because of her excessive demand and or depletion, dehydration itself can cause hypernatremia. So when she had this hypernatremia, we checked for the other causes. We repeated her urea. Urea was coming around more. Initially it was 20 range only. It worsened to 50s, and her IVC was like 1 centimeter completely collapsed. So she was in a volume depleted state, sir. So we calculated the fluid deficits for this patient. So her on the second day of admission, her when we calculated the total deficit, she was having around 3.9 liter of fluid deficit was there. So we will be correcting only 10 milliequivalents of sodium per day. So she required at least 1.6 liter that day, and so we corrected the fluid deficit. And after that,
what did you correct it with?
we correct with half normal saline, sir, or dextrose, D5 or 5% dextrose. Anyway, she is NPO, so we cannot give rails tube feeding or free water through the rails tube. Then after that, after 2 days, she again continued to have constipation. So they were planning to do a repeat decompression for this patient, colonoscopic decompression, but she passed stools after 36 hours, like after 3 days, sir. So they planned to restart on feeds, sir. So while we are planning to restart on feeds, the most important thing which we have to consider is a refeeding syndrome, because this patient was not taking much food since last few weeks to months, sir. So actually in case of refeeding syndrome, to prevent refeeding syndrome, we will...
Just for finishing off the intestinal obstruction part, any pharmacological treatments you can offer?
Yes, sir. Prokinetic agents should be offered, sir. So perinom can be started like 10 mg thrice a day can be started, sir.
What is Ogilvy syndrome?
Ogilvy syndrome is pseudo obstruction of the bowels.
Okay. Any role for neostigmine?
Yes, sir.
Pseudo obstruction, neostigmine can be tried for relieving the obstruction, basically improving
Motility.
And we can also try on erythromycin also as a prokinetic agent.
There are a lot of other issues with neostigmine. So considering her age and other comorbidities, probably would have given. Okay. Fine. You can continue with the remaining.
Prokinetic regarding erythromycin cisapride. Which one you prefer? Acute cases we can go for erythromycin. Cisapride for chronic. Only the thing we have to keep in mind is Cisapride erythromycin combination or cisapride itself may cause arrhythmias, tertiary dependent. Okay.
So when we are starting feeds, two things we have to consider is that whether it will get absorbed or not, or second thing is the dyselectrolytemia because of the refeeding syndrome. So we should start a feed in a very minimum, like 30 ml per hour and all, and we should every hour before giving the next feed we should look for RT aspirates. If at all it is not getting absorbed, then we will have to plan on reducing the feed dose. If it is getting improved, we can plan on increasing the feeds, like 25 ml after 4 hours, like that.
How will you know there is absorption or not? After the feed, after how long will you check for RT aspirate?
4 hours.
4 hours.
Start with 30 ml, check after 4 hours. If the RT aspirate is more than 500, we'll have
500. More than 50% of the total dose given. 500 കൊടുത്താലേ 500 വരത്തുള്ളൂ.
That is the position you will keep the patient.
While giving feeds, we have to prop up the patients.
More important. Okay, good.
Then we have to look for the aspirate. If the aspirate is less than 50%, then we can continue the feeding. If it is more than 50%, we will continue the feed and we will again monitor the patient. If that is repeating again, then we will have to add on prokinetic agents. And if again it is like that, if again RT aspirate is there, we will try reducing the feed. And again if RT aspirate is there, we will plan on giving erythromycin. Then we will be starting like 10 kilocalories per kg per day will be started, sir. So when we calculate as ml per hour, it will be coming around 15 ml per hour. And after starting feeds, we will have to monitor the electrolytes, because she was malnourished for this much days. So there will be increased demand for the electrolytes and all. So as this feed after feeding, all these electrolytes will go into the intracellular compartment for production of proteins and all. So there will be hypokalemia, hypomagnesemia and hypophosphatemia because of the refeeding syndrome. So that also should be monitored and should be managed. If at all she goes into refeeding syndrome, that should be managed, and then feed should be continued.
You can go for an active correction of electrolytes upfront itself, along with the once you start the feeds. Okay. Any role for parenteral nutrition?
Parenteral nutrition, if we are not able to restart on oral enteral feeds, then only we will be going for parenteral nutrition, sir. We prefer enteral nutrition more than parenteral nutrition, sir.
What are the forms of parenteral nutrition?
Aminoven is there, sir. Cabevan and pericabevan is there. Cabevan is usually given through central line. Pericabevan can be given through peripheral line and central line, sir. That will be given as 19 to 38 ml per kg per day will be given. That will be given per day to maximum 40 ml per kg per day will be given preferably through a central line, sir.
Peri you can give through
peripheral line also.
So as a patient, total care. So you are taking care of only pseudo obstruction.
Yes, sir. Then we have other in ICU, since the patient is bedridden, we will have to plan on frequent position change of the patient, because there can be a bed sore and all. Then thromboprophylaxis. Then when we are giving feeds, we have to prop up the patient. Then since the patient is having low sensorium, we should always anticipate aspiration and all, and that also should be taken care of, sir.
Any movements, physiotherapy.
Oral hygiene also should be taken
Hygiene,
care of.
all these things. Okay.
Okay, but